give some light conversation while people shuffle in. It's great to have you all here. These heart-to-heart sessions are really, I think, becoming the foundational events that HRI hosts on a regular basis, thanks to Katrina. And today we've got a bit of a star act. I'll come back to that. But first of all, I'd like to acknowledge we're on the traditional lands of the Gadigal people of the Eora Nation, and it's great pride to us that we have a significant, growing and powerful Indigenous health research group that's doing fantastic work. I've just come from 2 days retreat up country, Calum Nicholson's there in the front. But we pay our respects to all traditional owners, but particularly the past and present traditional owners of this area, which we're proud to be on tonight. And I pass my recognition also to every other Indigenous person in the audience. So tonight we're going to hear from one of our group leaders, but I think David's a little bit more than that, because he was been at the Heart Research Institute since the very beginning. The people who trained him and mentored him founded the Heart Research Institute, and ever since I first contacted the Heart Research Institute, I was on the board briefly 20 years ago, David was instrumental. David's also been a long friend and colleague, and I've seen his career develop around the world. He is a world expert in adolescent cardiovascular disease. And he didn't get it all himself because his father was a world expert as well in pediatric cardiology. And he's been a foundational figure at Royal Prince Alfred Hospital, University of Sydney and Heart Research Institute. He's also a phenomenal debater and was champions into school, university. My only chagrin is I never managed to debate against you. I'd like to challenge myself.
Not too late.
Anyway, we're here tonight and we also have Calum, but I'll hand over to Katrina, whose brainchild these events are and is doing a great thing. But I'd also like to thank everyone for coming, and we have people even from as far south as we have Mexicans from below the Yarra River. Deb, where are you? Who's here, fantastic supporter, and a graduate of congenital heart disease surgery as well. I hope you didn't want me saying that. Great to have you. Katrina.
Thanks, Andrew, thank you. Thank you for that introduction. Good evening, everyone, and thank you for joining us tonight for our first Heart to Heart for 2025. It's great to kick off our 5th Heart to Heart and the 2nd year of our series. And David and Calum, thank you so much for putting your hand up to be first off the rank for this year. We appreciate it. We're so pleased that you've made the time to join us tonight, and a big thank you to those who have joined us online as well. As I shared when we launched Heart to Heart last year, the Heart to Heart series is an opportunity for everyone. Everyone's welcome to come in to connect and to meet our research team, so that you can keep up to date with what we're doing at HRI and learn about the cutting edge research and the progress that the research team is making in tackling Australia's leading cause of death, cardiovascular disease. My name is Katrina Dowling, and I lead the Development, Philanthropy and Communications team here at HRI. And as Andrew said, tonight we're joined by Professor David Celemajer and Senior Data Analyst Calum Nicholson. And Clarissa Pitsikas is the head of our donor services team and a much loved member of the Philanthropy Development and Communications team. And Clarissa has kindly agreed to join us tonight and share her very personal story. So we thank you all. For those of you who may not know a lot about HRI and who may be new to the Heart to Heart series, I'd like to provide you with a very brief overview of who we are and why we're so passionate about the work that we do. So HRI is an internationally recognised medical research institute with a single focus on researching the causes and complications of cardiovascular disease. And we do that so that we can find better diagnostics, treatments, and ideally cures for cardiovascular disease. We were established 35 years ago in 1989 to fuel both basic research and translational research. And today, HRI is comprised of 14 distinct research groups that collectively form the Institute. And we have 2 locations. We've got labs here at our Newtown location, and we also have labs at the Charles Perkins Centre within the University of Sydney. So the team is focused on delivering, as I said, cutting edge research, and we've got a commitment to nurturing the best and brightest minds. And we'll hear from the best and brightest minds this evening, 2 of the best and brightest minds this evening. The rising stars in cardiovascular research, and we're also committed to facilitating opportunities for women building careers in research and science. That is a key priority for us. And why does this matter? Well, we exist because we want more people who are impacted by cardiovascular disease to have more time with the people that they love and care for. So that's why we're here tonight. So I'd like to now formally introduce our speakers for this evening. We're joined tonight by esteemed cardiologist, Professor David Celemajer, Clinical Director of HRI and leader of HRI's Clinical Research Group. And as Andrew said, he is also a Director of Adult Congenital Heart Services at RPA Hospital. David is a cardiologist and researcher, a Rhodes Scholar with a Master's in Science from Oxford University, a PhD in Paediatric Cardiology from the University of London, and he is a world-leading expert on congenital heart disease. In acknowledgement of his incredible work related to congenital heart disease, David was awarded an Order of Australia in 2014. So the focus for our conversation this evening is the work that David and his team is undertaking in relation to congenital heart disease, and specifically the work that's being undertaken to develop what is termed a whole of life care of people born with serious heart conditions. With advances in research and clinical care, people with congenital heart disease are living longer, which is a great thing. Where in years gone by, many patients may not have survived beyond their infant or teen years, we see now that many patients are now not only surviving into adulthood, but like Clarissa, they're thriving. And David's work is focused on helping people born with serious heart issues to thrive. I'd also like to introduce Calum Nicholson. Calum is a senior data analyst within the Clinical Research Group. Having completed his Master's in Health Data Science in 2021, Calum is a key member of David's team and is focused on managing the data collection and analysis for the first national Congenital Heart Disease Registry. So it's amazing work that you're doing, Calum. The format for tonight is slightly different. Rather than it being an interactive discussion to start, I'd like to now invite David and Calum to come up and present on their work. And we'll then have a Q&A session with Clarissa, and we'll also invite questions from the audience. So, David.
Thank you both, Katrina and Andrew, for those lovely words of introduction. And can I just say, I want to start by acknowledging 2 special groups of people. One is people who devote their lives to science, because it's not always the easiest career in the world, it's not always got the best job security, but boy, when you do it right, it has the best fulfillment. And I think it's a bit of a precarious existence, but it's a wonderful existence, and I want to pay tribute to those people in the audience and online who do that. And also, especially, there are some people in the audience that I look after, and I always ponder how it must feel to be told that had you been born before 1960, you wouldn't be alive anymore. It's a bit of a mind freeze to wonder how those people feel. And as Andrew and Katrina said, many children with congenital heart disease, in fact, the success story is so grand that there are now more adults with inborn heart disease in Australia than children. It's extraordinary. And they're almost 90% of them wouldn't have been alive if not for the advances made by the pioneers in the 50s and 60s. And they do lead fulfilling lives, but every so often life throws a hurdle at them. And they unexpectedly have to come into hospital, unexpectedly have to have a procedure. And by and large, the resilience and merit that those people show to get through those unexpected hurdles is very humbling, and I want to acknowledge that. So what do we do? You know, everyone thinks of cardiovascular disease and they think of it as coronary disease that affects people in their 60s, 70s, 80s and beyond. But there's much less of a focus on this extraordinary congenital heart disease, but it is the commonest inborn abnormality of any organ. It affects about 1 in 100 children, which is a lot. If you think of your class at school that might have had 100 or 200 people, it means 1 or 2 of them had congenital heart disease. You may not have known. Okay. May need the idiot's guide to the page down button. Space bar.
There's something you can't do.
And how about advance it? Okay, great success. Thank you very much. So the reason I became interested in it is because when children turn 13 or 14, the pediatric cardiologists, they outgrow the beds. But the adult cardiologists who are used to looking after the common adult problems don't really know how to do it. And so me and a lovely woman called Leanne Grigg in Melbourne both took ourselves off for 3 years, and having trained in adult cardiology, trained in paediatric cardiology. I did mine at Great Ormond Street in London, and Leanne went to Toronto Hospital for Sick Kids, and I set up a shop in Sydney and she set up a shop in Melbourne, and that was 30 years ago, and thereby hangs a tale. But what we've found out is that it's tempting to focus on what's going on with the heart, but we are much more interested in the whole package, the body around the heart and the life journey. And we now understand that if you're born with a heart problem, not always, but sometimes, that can result in physical problems, mental health problems, emotional problems, difficulties finding a partner, a job, having a child, doing sport. The things that many of us take for granted are challenges. And we've introduced this concept, it's not a very clever concept, of whole of life care, but it's something that's not widely practiced. And there are many knowledge gaps that over the last 15 to 20 years we've tried to address. What are the genetic causes? There are some that are syndromal. There are some environmental causes, most chiefly the one we understand best is alcohol. We don't even really understand the outcomes of the main congenital heart diseases because there are about 100 of them, and they all have different life courses. But when we put together information from all around Australia and New Zealand, instead of me having 10 patients with disease X, I can refer to the last 300 patients with disease X, and gives us a lot more confidence in saying what's going to happen in the future. We're now starting to understand the lifetime burden of disease, and we're really keen to develop the best models of care. And to that, we talk to people with congenital heart disease, we interview them, we say, what could we do better? What do you want from us? And you would think that's pretty bloody obvious, wouldn't you, to ask the patients what they want? But I'm sad to say the medical model is somewhat paternalistic or maternalistic. I remember interviewing a kid about 5 years ago, and I said, hypothetical question. Frida with breast cancer doesn't want the treatment you prescribe because she doesn't think it's suitable for her. What's your response to that? And this 23-year-old responded, well, I'll tell her, I'm the doctor, I know what's best for you, and this is what's going to happen. But of course, as I say it sounds so stupid. But we had to turn that on its head and understand from the patient's point of view what they want and what are the best models of care that we can afford in the context of the Australian healthcare system. So we have a big team employed through the HRI, and I've got a few of the main members there, and they've got fantastic skill sets. You'll hear from Calum, who's a data scientist. Jeff Strange leads 3 of the biggest disease registries in the country. We've got statisticians, we've got psychologists, we've got a magnificent team that have delivered on a project, and we've been very lucky to be government funded to over $10 million over the last 10 years to deliver some of the work I'm going to show you about briefly. So I'm going to talk about 2 things, and I'll try and be very brief. One is what our major projects are, and the other is to give you some insights about what it might be like to be an adult with congenital heart disease and how we look after them. So we established something called the National Registry. And when we started, the Australian Institute of Health and Welfare thought there were 50,000 people with congenital heart disease in Australia. We already have 80,000 in our database, and we think there are probably another 50,000 out there. So can you imagine a situation where the government thinks there are 50,000 people with condition A, but there are actually 130,000, and it takes researchers to go and find that out. And why does that matter? because you've got to plan for their services. And you've got to plan as to how you're going to look after them, and you've got to know the number of them, where they live, and how complex their disease is. So we have these interesting groups that we've called Group A and Group B. The important part about Group B is they're 1,500 people where we've done a really deep dive on what life is like for them. We've got them to do surveys and visits so we understand in granular detail more about their journey. We've had lovely philanthropic funding to study the intersection between disability and congenital heart disease, like cerebral palsy, Down syndrome, autism, ADHD, and how that impacts on heart disease and vice versa. We're looking at the genetics, and one of the projects we're really excited about is what we call the CHD Knowledge Bank, and that's we're going to get everything that's known about CHD and put it on the internet for everyone to know about it too, as a free resource. So if you live in Bunbury and you need a dietitian that knows something about congenital heart disease, you can look it up. If you want to know what genes cause congenital heart disease, you can look it up. If you want to know what the latest research on the outcome of single ventricle heart is, we're going to make that accessible as well. And that's a big and important project. This is the Group B studies that we're doing to understand the psychosocial and mental health dramas and the neurocognitive function of many of these people. And this is basically this is one slide to summarise how this all works in Australia. We've got single centres, disease-specific registries, surveys, and we put them all together with every state and territory to do two things. In the red box, the characteristics and burden of CHD and how to manage people through their whole of life journey. And we publish a lot because that's the way that research gets disseminated. This is an important paper that Calum was the first author on, describing the registry and the methods. And he'll present some of these data in more detail, but we collect data about the age of the people, the complexity of their disease, when they were last seen. So for example, on the top of the graph, you can see that new patients who come into the registry by their age range. So we collect an enormous amount of data, but it's not for its own sake. It really, truly informs the best models of care and how we can best advise our patients. And because we now have on the bottom line, this is a couple of months old, 68,204, we screened 359,000 people. We've now got 68,214 people. The next biggest disease registry in the world is 35,000. And we're Australia. For goodness sake, we're Australia, one of the smallest countries in the world, and we've got double the number. This is a major international resource. Now, I want to touch a little bit on this concept of an adult, because there was no such thing as an adult with congenital heart disease before 1990. This is a very interesting slide because I'm going to wander over. That big bulge is very bad for you. This is a lead singer of a major Australian band who we did some screening on and found that he had that, so he took a little bit of time off singing to get fixed. So we think in New South Wales there are about 10,000 adults with congenital heart disease, but only about 2,500 of them are under specialist care. In addition, there are 500 to 600 new cases every year, and they're increasing both in number and in complexity, because in 2000 you could fix a more complex heart than you could in 1980. So fast forward 20 years, we're seeing really, really complicated hearts, people with really, really complicated hearts come through. And so there are now more adults in New South Wales. So just to map that graphically, the bottom line is what used to happen, the top line is what now happens, and so the grey line is all these new people who wouldn't have survived but now do. Now, you have to put together a big team to do this. So it's, I celebrate socialist medicine because that's how you put together a big team, because many of these people, I don't want to be blunt about it, but because they haven't had great job opportunities and they haven't had the same opportunities that you and I take for granted, they don't often have extra cash. So we have to do this through a public hospital system. We have to provide plumbers, which is what I am. We have to provide x-ray doctors, interventionists, surgeons, electricians, blood specialists. Oh my God, I've got 3 patients at the moment who are pregnant and I lose sleep over them. Pregnancy is a strain on anyone's heart, but if you've only got 1 pump rather than 2, pregnancy is a journey. Last week we delivered a woman who could only get to 23 weeks in her pregnancy. Her baby was born at 514 grams. And at the moment, both mother and baby are doing well, but that's a tough job. We need genetic counsellors, we need tons of psychology support, and our nurses lead the way. These are the aspects we end up dealing with, far beyond just is the heart pumping well and is the electrical system working well. Employment, insurance, social interactions, contraception, exercise and sport. So to put all this together, we wrote, through the Cardiac Society of Australia and New Zealand, a guideline about how to look after adults with congenital heart disease. And that's the way you get standards of care promulgated nationally and internationally. So this sort of is the trajectory about how it's come about. The operations are better, the survival is better, the intensive care units are better, the surgery is better. And that's what's led to the growth. So I'm going to finish in a moment, but I just want to show you how funny some of these hearts can be. So the simplest ones are holes in the heart. But then there are these moderate complex ones. This one, Epstein's anomaly, a valve that should be there is way down here and doesn't work properly. In this one, the main blood vessel out of the heart called the aorta has a narrowing in it, so all these other blood vessels, like a bypass, have to go around it and they can cause all sorts of problems. And then there are the really complicated hearts, which have got funny names, but they're combinations of holes and valve abnormalities. And then at the toughest end of the spectrum are generally people with one pump rather than two, or where the blood vessels that go into or out of the heart are completely misarranged. But there's almost nothing we can't handle at the moment. When I was a registrar, and Andrew will remember this, the one on the left, hypoplastic left heart syndrome, those children were allowed to pass away in the first 2 or 3 days of life. Now they routinely live until they're 20. And I'm talking 1990, when these children were thought to be non-savable. And they've got all sorts of funny names, but just to show you the variety of hearts that are compatible with long-term survival. And so I just want to conclude on that because it's such a special area to be involved with. The adult congenital heart population is growing in number and complexity, particularly in Sydney and Melbourne, which were pioneers in the 1970s. And it's such a special area to be involved in because genuinely, these are the most complicated patients. They are far more complicated because they've got so many different kinds of problems. And we took a view 20 years ago that the more research we could do into these conditions, why they happen and what people with them can expect and how we can best help them on their whole of life journey, the better we would provide the community with the service we want to. So CHD research at HRI is truly world leading, it's highly impactful, and we provide both clinical and research care, and it's a privilege to be able to do it. So I might hand over to Calum to talk a little bit more about the nuts and bolts of the registry that we've established.
Hi everyone, thanks for coming along. It's great to have a chance to talk about the registry. I've been working in this project since 2020, kind of helping guide it from a small single centre data collection to something that goes across 2 countries. So it's really nice to be able to talk about some of the details about what it is and what we're doing with it. So a quick top level overview. The registry, who do we aim to collect? Ideally, we want to collect every single person in Australia and New Zealand with congenital heart disease. At the moment, we're collecting every patient with congenital heart disease who presents to one of our participating hospitals. And the minimum period, we want to start from 2010 onwards. So we've got a really good collection for at least a decade, maybe getting towards 15 years now. Our minimum data set, the basic set of information that we're collecting is the demographics, who is the patient, the diagnosis, what kind of congenital heart disease do they have, and then what kind of procedures and interventions that they had relating to their heart. And from there, we have space to collect a lot of information about their medical history, so that's what we're looking towards in the future. Ultrasound, X-ray, MRI, kind of any kind of investigation you could think of. And we really want to focus to make sure that we can continue this minimum data set collection to be a long-term and ongoing follow-up. So just a quick overview, we have 11 hospitals that are currently contributing, 10 in Australia, one adult and one child hospital in those 5 Australian states, and then 1 hospital in New Zealand. One of the nice things about congenital heart disease from a data collection perspective is that it is a specialty that's centralized in a lot of care centers, so you can kind of get a lot of the population from only 11 hospitals. We don't have Tasmania here, for example, but that care is serviced by the hospitals in Victoria, and same for Northern Territory and ACT for other hospitals. So it gives us a nice way to get a very good overview of the whole population, which is really nice. So with that data set, we've been able to collect our minimum data set from all of these 11 hospitals now. And I think we can confidently say it's the world's largest congenital heart disease registry. So back in 2021, we did a bit of a review of all the other registries around the world. What are their strengths, what are their weaknesses, and what can we learn from them? So you can see some of the best ones are maybe hitting 50,000 now. And you'll see this flowchart is a bit of an update from what David said. So it's what David showed. David's was from the paper that we published in 2023, and this is hot off the presses. So this is our data as of the end of 2024. And it was at about 60,000, now we're at about 80,000 patients. So really a huge improvement. And a lot of that is inclusion from New Zealand, which we were able to collect in 2024. So it's really nice to point to say that we've completed our minimum data collection from all of our participating hospitals, and we now have this huge data set to work with as a piece of infrastructure moving forward for the next decade, hopefully. So I want to talk about a few things that we're doing with the data, and then a few of our future directions. One important thing is we want to be able to enrich this data set. We have 80,000 patients. What can we do to know more about these people? And a really important project that I'm really excited about is health data linkage. So this is quite an increasingly more common technique that's done in epidemiology in Australia, and essentially it's taking your data set and linking it with administrative data sets that are held by the governments in Australia that manage our health system. So this includes things like Medicare benefit schedule, pharmaceutical benefit scheme, hospital admissions, ED presentations, and the National Death Index. And so some of this stuff is really happening for our group in real time. We got about half of the data that we've been expecting to get about 2 weeks ago, and I'm just starting to crack it open, and our team's just starting to make sense of it. One of the examples of the scales that we're working with is the MBS data set has 18 million rows. So it's kind of the biggest data set I've ever seen. It took me 5 minutes just to load it into my computer, so it's quite exciting for a data guy like me, to be honest, and we're pretty keen to get into it. So I said that we had, half of our data from the linkage. That's because we have 2 cohorts. First cohort is the data from the registry, the people that we've collected from specialist centers, so people that are known to specialist care. And the second cohort, to supplement that, what we're calling cohort 2, is people who've had a hospital admission from 2010 onwards that includes a congenital heart disease diagnosis that we have not already collected in cohort 1. A bit convoluted, but the point is, it's people with CHD who aren't already known to specialist care. So that's going to help fill any gaps that we have, and we don't even really know how big that's going to be. So we're expecting that in June 2025, and that will help to get us close to what we think is a population level data collection. And what can you do with a population level data collection? Well, there are a few main research questions that we can answer, and these look quite simple, but I mean, even these really basic questions you can't really answer without a data set like this. So even something as simple as how many people are there living in Australia with congenital heart disease right now, we can't confidently say that. And this is going to give us some really strong evidence to understand that information. And then how many people with CHD are born each year? So what's the incidence, what's the growth rate? Where do the people live? Where are the services? Are there gaps in the access and equity of care? How are people interacting with the health system? So are people seeing GPs more? Are they presenting at emergency departments at a higher rate than other people? Where are they presenting, and these kinds of things? Following on from that, how much does it cost to deliver this healthcare? And then also, what are the trends associated with mortality? So that's a lot of population level information that we can understand from this data set that we couldn't before. So that's something that we're maybe 6 months away from uncovering. That's something we're really excited to get into. And following on from that, David's mentioned this project a little bit, the Group B study. I also call it the CHD profiling study. So this complements that population level research really nicely with a deep dive into what it's like to live with congenital heart disease and what kind of outcomes do people with congenital heart disease have. So David's kind of gone over this. I'll go over it pretty quickly, but the 4 hospitals from New South Wales and Victoria that are in the registry are where we're recruiting patients from. And the registry has proved a really important tool for recruiting patients for prospective research. So that's a really useful tool that we've managed to create there to help improve our prospective research, maybe get better recruitment in clinical trials and things like that in the future. David's gone over this a little bit. These are the basic ideas, the top level overview of the things we're collecting: physical health, quality of life, mental health, cognitive functioning, a whole suite of lifestyle details, and this is also being linked to the Medicare and the pharmaceutical benefit scheme. So this is in progress right now. Our team has been doing great work to finish this data collection, and we're finishing our data collection in March, and we have just over 1,600 people collected now. So even though I say it's a smaller number of participants, it's not really a small number in the grand scheme of things. So that's really exciting. I think we're all very excited to kind of finish that data collection and move on to the next phase for that. Another project that David mentioned, I'll go into more detail, is the patient engagement study. And this one's a bit different for us, especially me, someone who's really used to working with data. This is a qualitative study where we do interviews and focus groups with people with congenital heart disease to understand what it's like to receive care as someone with congenital heart disease. So very word-focused research compared to the numbers that I'm normally more comfortable with. Some of the aims that we're interested in is to identify common themes that are occurring in these interviews, uncover and understand the patient journey. What is it like for the whole of life to go through that? And then with the focus groups, we want to go through a patient-led design process to come up with a set of ideal care guidelines. So some of the work that's come out of this is kind of this graphic here, this model that we're starting to put together. So the team's done about 43 interviews with people, transcribed them, done a thematic analysis to understand what it's like. And this is an initial overview of what the care journey starts to look like for someone with congenital heart disease. So obviously it starts with diagnosis, which generally happens in childhood, but can happen in adulthood. Pediatric care goes on to until 14 to 18 years. And then we move to transition to adult care. And this is something that's been highlighted as a really important aspect of the care journey, that successful care and well-managed transition to adult care is important to ensure long-term follow-up and that whole-of-life care that David has been talking about. And here, these 4 points here, these are the kind of 4 pillars that we've identified as important factors for ensuring the patient journey is a good experience and a successful experience. So this is really important, and what will be coming next when we do the focus groups in March is to kind of take this idea and the themes and people's feedback to start to develop care guidelines that have been led by patients. So that'll be really exciting information for us to finish off this study. The last piece I want to talk about is something that I've been working on a lot. Geographic information systems. Sounds fancy, but it's really just where do the people live. So, we've got 81,000 patients, most of them we've got an address for, so we can start to put information on a map and say very clearly where are the people with congenital heart disease in Australia. Being an area that has such specialist care requirements, it's important to make sure that we have equitable access to healthcare, we have efficient use of healthcare resources, and people can get to see the doctors that they need to see. So this is something we put together a few years ago when we only had the New South Wales data set, called the clinic planning tool. It's an idea where you can see where the patients live on a map, and you can see where the clinics are on a map, and then you can see how long it takes to drive to your nearest clinic. And then you can say, okay, well, if I put a clinic somewhere in Western New South Wales, how long does it take to drive now? And how many people can I reach if I put a clinic here versus if I put a clinic there? So very practical tools that we can use with simple information like an address. And moving forward, we've now got, obviously, the data set's much larger, so we're excited to take those initial frameworks and put them across the whole country. So this is coming from those 81,000 patients, showing where they live across Australia, and so we want to work towards driving more insights from this data to be able to understand where are the hotspots, where do people live, does the distribution of people with congenital heart disease differ from the general Australian population, and if it does, what can we do to make sure that we're delivering care effectively. So yeah, lots of stuff to be going over with our work. That's just a bit of a brief overview of the various bits of research that we're going on to now. So thank you very much.
Thank you, Calum. Thank you for that very comprehensive overview, and thank you to you too, David. We're just going to get some chairs up here now, and I'd like to invite Clarissa Pitsikas to come and join, and David, if you would come and join as well. Before we get underway, Calum noted one critical element of success in determining the whole of life journey, and that was the importance of family as a pillar of support in a patient's journey. So tonight, I'd also like to thank Clarissa's mum, Sandra, for being here, and her cousin, Vanessa, as wonderful family members who've come along as a show of support. And I know from working closely with Clarissa that she couldn't get through things without you. So I thank you very much for being here tonight. So Clarissa, you were born with congenital heart disease, and you've been a long-time patient of Professor David Celemajer. Tell us about your story and the challenges that you've faced through life from a heart health perspective.
So David, David's late father actually diagnosed me as a newborn. If it wasn't for him today, I wouldn't be sitting in this room with you. I was diagnosed with a congenital heart condition. My first surgery was at 6 months old. Apparently during that time, I stopped breathing and almost died. My next surgery was at 13 years of age. After that surgery, I was relatively healthy with no complications.
You okay?
Yep.
Doing good. You're amongst friends.
But in my mid to late 30s, that all changed. I came home after a day's work, went home, relaxed, had some dinner, took my dog Kai for a walk. And when I say a walk, I mean a short walk around the block with a small dog that doesn't walk very fast. As I was heading home, I noticed I felt a bit strange. I felt like my throat was closing up, had pain in my left arm, and my heart was racing. So I got myself back home as soon as I could, got inside, brushed it off, thought, I'll be fine, popped into bed, thought nothing of it. But my heart was pounding. It was literally feeling like it was beating out my chest. So I called my parents on the home phone. My mum answered, and I said, hi. I said, I don't actually feel well. Sorry for calling so late. She's like, that's okay. What do you mean you don't feel so good? I said, I feel like my heart is about to explode. So, fortunately for me, my parents live not so far away. They came straight over and noticed, took one look at me and called an ambulance. The ambulance thought I was actually having a panic attack. That was not the case. My heart was racing at 220 beats a minute, if not more. So after that, I arranged a follow-up appointment with my cardiologist at the time and was told it will happen again. And it did. Every 6 weeks, to be exact, for about a 6-month period. That year itself was quite a difficult one, personally and professionally. So when this episode stopped, I just brushed it off and thought, okay, it was stress related. Fast forward 6 years and that all changed. Those episodes are back. And when I say back, they're back almost every day. Except this time, I don't have any symptoms. I don't feel anything. My left arm doesn't hurt. I don't feel like my throat is closing up. It doesn't bother me. The only way I know is I've got a little bit of flutter and I get an alert on my phone or Apple Watch. So I do as I'm told. I take 2 tablets daily, get on with my life or my day, and that's it. But as my parents and my sister have said, with Clarissa, expect the unexpected.
Thanks, Clarissa. Thank you. That's a very scary condition to live with, I'm sure. Where you don't know from day to day what your heart's going to be doing in terms of its rhythm. David, Clarissa talks about the ongoing need to monitor her heart rate and deal with the spikes in heart rhythm that are occurring. Why does this happen, and why is it happening for Clarissa? And how are you using technology to assist your patients in managing their conditions like this?
So everyone knows that the heart's a pump. Not many people think that it's a pump that also has a battery. So just like the car, every engine needs a battery. And if you want to lift your right arm, you think, I want to lift my right arm, your brain sends an electrical impulse. But if you think, I want my heart to beat, you don't have to think about it because it's got its own inbuilt battery. But in some people who have had surgery on their heart, little scars can form near where the heart's own electrical system is and can cause a sort of short circuit that can fire off independently. And the first time I met Clarissa, her heart was going at 220 beats per minute, and that's not a very usual thing. And it turned out to be due not to one little short circuit in her heart, but to 7 different ones, which is not an unusual situation in someone who's had a lot of surgery on their heart when they're a baby, because there's lots of scarring on the heart that grows, and that can cause big problems. And in general, there are 3 ways we treat it. Medications sometimes work, but not always, and they can have side effects. We sometimes do a procedure called an ablation, where you try with a little catheter threaded up to the heart to find out where the short circuit is and give it a little micro burn to get rid of that short circuit. And sometimes we can use these very sophisticated devices like pacemakers and defibrillators to prevent the catastrophic complications of really fast or really slow heartbeats. So technology has been fantastic, but in many people with inborn heart disease, these electrical problems can be an ongoing battle.
Thank you, David. With that ongoing battle, Clarissa, talk to us about some of the psychological or mental challenges that you faced, living with the condition that you do have.
Yeah, so mentally and physically it can be draining, going from one appointment to another, one hospital admission to another. It honestly sometimes feels like it's never going to end, and to be honest, it's not, but that's all I've ever known.
Okay. So in terms of progressing from being a child with congenital heart disease to being an adult, what's been the greatest challenge for you in making that transition into adulthood, or some of the greatest challenges or hurdles that you've faced?
Yeah, so for me personally, the biggest challenge for me has been finding an environment or work environment that has been acceptable, understanding, flexible with my appointments, unplanned and planned hospital admissions, and the ongoing tests that I have. When I first started here, I was completely fine. 6 months later, I pretty much spent 6 months in hospital, in and out. So being able to work for a company where I have that flexibility and can still be in a role that I'm fully capable of doing without knowing that I feel like I'm being not able to fulfill a role at my capacity, which I can, but yeah, I'm just going to be in and out throughout my time here.
Yeah. Well, you're a much valued member of the team, and yeah, we appreciate you coming in and showing the dedication that you do, particularly in the face of the challenges that you're facing. So, David, you talk about the need for a multidisciplinary approach from a healthcare perspective for people living with congenital heart disease. You spoke to us about some of those multi-disciplines or different disciplines. Can you tell us why this approach is so critical and why it's needed?
Thank you for that. It's because no single person has the entire skill set. It's a little bit like a symphony orchestra. You couldn't possibly imagine a violinist being great at the bassoon and on the kettle drums. There's always a conductor who has to orchestrate everyone, but you rely on experts in each field. And it takes time to build such a team. When we wanted someone who could do MRI scans on complicated hearts, we sent them away to London for 3 years, and the person who does that did his PhD at the Heart Research Institute to learn how to be a great scientist as well as a great clinician. So it's sort of, it's the 10,000 hours to be good at one thing, and you need 10 people who have done that. Men, women, old, young, people who are empathetic, people who are experienced, people who have certain skill sets. And it takes a while to put together a team, but it takes a village. And if I can just say, hats off to Clarissa. She's such an extraordinary person.
Yes.
But for every Clarissa, There's a mum, there's a dad, there are friends, there are aunts, there are cousins, there are workmates, there are social friends. So when we say there are 80,000 people who have congenital heart disease, it's probably 20 times that number whose lives are directly impacted by congenital heart disease. So in the same way that we've got a big team at work, they've got a big team at home.
Yeah, absolutely. And you know, it does take a village. And on that point, I'd actually like to also thank Elle Pendrick for joining us tonight too. Elle is another superhuman who lives with congenital heart disease and has become a great friend of Clarissa's and is a long-time patient of David's as well. So thanks for being here tonight with us, Elle. Clarissa, tell us about your relationship with David as your treating clinician and other health professionals that you've engaged with through your journey. What's been the fundamental care that you've really needed and that you continue to need?
Since seeing David, I've had the most exceptional care and treatment from day one. David has never put me in a position where I felt like I've been put in the too hard basket. He's always made himself available to me, whether it's in person or by email. As one of another patient of David's, Elle Pendrick, who is one of the HRI ambassadors, has said, David is the GOAT, greatest of all time. He's amazing.
That's good. Oh, that will be your new name from now on, David, the GOAT. Okay. So, David the GOAT, can you tell us, please, how can people get involved in your work? And have you got any final, take-home messages for people today that you might like to share?
Yeah, I think it's that every advance we make is based on scientific research. So when I spoke to you about ablations or defibrillators or pacemakers, they don't happen by accident. They happen because of funding that leads researchers to produce results. But very few people with congenital heart disease are cured, and they do need ongoing care, and it has to be delivered sympathetically, empathetically, but also expertly. And the expertise only comes from the research investment that allows us to provide the right standard of care. And happily in Australia, we're in a good position. And we want to export our expertise so that people all around the world can enjoy the fruits of some of the research that we've done.
Yeah, terrific. Thank you. So and I think that's a great point to note that, the work that you're doing and the work that a lot of the team, or all of the team here is doing, does have that global impact. So yeah, it's fabulous. Clarissa, are there any leave behind messages for the audience that you might like to add? And if you could impart one thing from your lived experience, what would that be?
Yeah, so every journey is different. You, as the patient, know yourself better than anyone. If you don't think something's right and you're not getting the answers, seek another opinion. You are your best advocate, but you've also got support out there, whether it be family, friends, whoever it may be. My experience is you're always going to come across a hurdle, and you've just got to have a good mindset and just go with the flow, get the right support, speak to the right people, and make sure you're 100% happy with your decision, whatever that may be.
Terrific. Yeah, thank you. Thank you very much, Clarissa, for sharing your story today. I know that it's, pardon the pun, something that's very close to your heart, and that you find it very difficult to talk about it openly. So yeah, thank you for bravely sharing today. And thank you to you, Professor David Celemajer, the GOAT, and to Calum Nicholson for making yourselves available today to share and update us on the very important work that you're doing. So I'd now like to open up to the audience. Are there questions that people have? Anything that you would like to ask? Yes, Auntie Carmen Parker.
Thank you for that presentation. It was pretty phenomenal, and thank you, Clarissa, for sharing your lived experience and courageous to be in front of an audience and people like us to share that. Yeah, thank you so much for your experience and sharing that, and I just want to acknowledge your family too, because going through the things that you went through, it's very important to have your family behind you. But I'm really interested in, you've got 80,000 odd people now, and sorry, I should say who I am. So I'm actually part of the Durrani Centre. I'm also one of the cultural leaders there. And I just happen to be in Sydney, and it's very rare for me to be in Sydney at HRI, so I thought I'd come along tonight. I'm glad I did. It's a really great symposium tonight. But I was really interested in the data around how many Aboriginal and Torres Strait Islander people were you able to identify in there, and more importantly, the spread across Australia, because that's probably the area that we're interested in, obviously. And similarly, the patient experience, like how many Aboriginal and Torres Strait Islander people did you actually, talk to about their patient experience? And because I'm actually from Queensland, I'm more interested in Queensland at the moment, but needless to say, it'd be good to have an analysis of the nation. So I just wondered whether there was an opportunity just to explore a comment on that.
I might briefly respond if that's all right. So you may not like the answer.
Oh,
We're not actually allowed to identify the ATSI patients in our survey as ATSI, because there is a whole ethical framework around the privacy of Indigenous patients that's quite difficult to negotiate. I can tell you that we have many, and I can tell you that they're certainly represented in our survey, but we're never going to be able to report on them separately. I can also tell you that we've spoken about congenital heart disease, but a lot of work by the Australian government is done on childhood onset heart disease, which also includes rheumatic fever, which, as you know, is a sort of 95% Indigenous population. And we haven't spoken about it tonight, but a lot of our research also involves going into communities and delivering care for rheumatic heart disease on country. And that's something that we, again, can't identify Indigenous people separately, but because 95% of the sufferers are Indigenous, we understand it.
It's sort of an overlapping question, but we know some of these patients, and one we have online, lived in regional and remote areas, and all these centres are right in the centre of the CBD. How much is that an issue, and are people forced to come near you to get the care they need?
So on the research side, we have mandated that 20 to 25% of our samples be regional and remote. About 5 years ago, one of my wonderful colleagues, Rachel Cordina, who's also on staff at HRI and leads a wonderful research project in exercise and heart disease, Rachel established a number of outreach clinics. So I'm off to Wagga next week, Rachel goes to Nowra, Dave Baker goes to Tamworth. So we now, because, I said that a lot of people with congenital heart disease don't have a lot of money, so coming to the big smoke for their care is hard. So we now go to them. And so we've got 6 outreach centres across New South Wales. And the Western Australians, the Queenslanders are not quite as advanced. The Western Australians for 20 years have gone to Port Hedland, to Karratha. So outreach is a big thing in congenital heart disease, but it takes a lot of effort and it's not particularly well funded. But in the research, we are going to be able to extract a lot of information about rural and remote patients.
Juggling microphones. All right, are there any other questions?
We have a couple from online.
Terrific.
Okay, so the first 2 are from Ella Online. So she's just asked, how can people with CHD find the results of the registry findings easily? And how has Australia become international leaders in developing a national registry? What has helped us do this?
So the CHD Knowledge Bank that I spoke about is where all the results, so they're going to be published in the scientific literature, but we know that that's not very accessible. So we're going to have this big shiny CHD Knowledge Bank, and we're going to make sure everyone knows about it, and we're going to have up-to-date knowledge from not just the registry, but everything that's important that we think people with CHD might be interested in. But certainly the registry's going to be in there. And the second part again?
How did you get there? How did you succeed?
Oh, well, it's probably because of Medicare and socialised medicine. In Scandinavia, everyone has a unique identifier when they're born. You know, you're Swede 1859234, and that follows you through life. So it's very easy to do registries in countries like that. The next best thing here is a Medicare card, which allows you to track the journey indirectly. And Calum talked about establishing these data linkages. It's taken us 4 years to get permission and funding to link medical records with outcomes data, but it's basically Australian infrastructure, know-how and funding.
And determination by the team.
Do we have another question online?
So we have another question from Nicole Roberts, and she's asked, what is it that brings us to the top of leading research and information about adult CHD, apart from HRI and the GOAT?
Hi Nicole. I think it's because there were a group of specialists in the 1960s that started congenital heart disease in Sydney and Melbourne, where really the only other two centres in the world were London and Toronto. So there's a very rich tradition of Australian excellence in this particular field. So there are some areas where Australia is fantastic, really fantastic, I mean many areas, but it's often where some pioneering people have inspired future generations of clinicians and scientists to carry the torch, if you like. And I think that's the case with congenital heart disease. People like Alec Venables in Melbourne and Tim Cartmill and my dad in Sydney. So it's the tradition started early and it's been carried on.
Now, we're very honoured to have Peter McGoran, chair of our board, here tonight, and I think Peter's got a question.
The honour's all mine. Thanks everybody for being here. Thank you, Clarissa and David. A little off topic, David, looking to the future, and I hope you're not annoyed at me, because I don't want to be one of those bug-eyed people who think that there's a miracle cure for everything. But in November there were banner headlines about Dr. Andrew Timms, an Australian researcher based in Houston at the Texas Medical Center, about an artificial titanium heart. There have been artificial hearts before. I visited him in 2018 when I was in the service of government to make an assessment, and it's legitimate, and he had Billy Cray, the great inventor, as his mentor. So is it the Holy Grail, or is it potentially achievable in the years to come?
Oh yeah, I mean, I think an artificial heart, you know, people have been at it for a long time. The Jarvik 7 was in the 1980s, I think. And the problem has always been that when you put blood on a titanium or any metal surface, it clots. And so there have been some really serious engineering challenges. But at the end of the day, putting in an artificial heart is something you'll only do when someone is terribly, terribly sick. It's really, what people's hope is there aren't enough transplant organs. About 1 in 2 people who are on a transplant waiting list die on the transplant waiting list for want of an organ, which is because of random breath testing and seatbelts. But you know, a heart is always better in the person who was born with it than in someone else. So I celebrate random breath testing and seatbelts, but it's been terrible for heart transplantation because the number of donors has taken a nosedive. So the impetus for the artificial heart is as a destination therapy instead of a heart transplant. So it's always going to be for the very sickest people. And I think, you know, maybe Clarissa would answer, if someone could offer you a new artificial heart that would last 10 years of good health and then would run out of steam, would you take that, or would you take how you are now? It's a hard question, isn't it?
It is a hard question. I think I'd probably, I don't know, maybe stay as I am. It's all I've ever known, so, you know, I cross each bridge as it comes. And no, I don't think I would, not if it was only for 10 years.
Yeah, so we didn't rehearse that. I think it's a fantastic thing, but it's going to be for a relatively small number of people with very, very, very few places to go other than that.
Thank you.
Hi. Oh, that was loud enough. Clarissa, very well done. Very well done. So in terms of funding, I'm interested in the equipment. So you say that, Clarissa, you use equipment. Is it mainly your watch you use, or is it's all your watch? Yeah.
All my watch.
Okay.
And me knowing when I've got a little bit of a flutter.
Yeah.
I notice a slight difference in myself, but it's mainly my watch.
And in terms for you, what is the equipment that you need in general to make sure that people get through their day?
Lots.
Yeah.
So this morning I closed a hole in the heart on a 26-year-old with a little piece of nitinol, a plug that's about that big and costs $12,000. It didn't cost the person $12,000, it cost Mr. Albanese $12,000. But the gear we use is really expensive. I have a guy down in ICU at the moment who has sadly had a sad life, used a lot of methamphetamine, heart not moving at the age of 42. We put him on a heart-lung bypass machine for 2 weeks. Then we had to put in a little propeller in his heart for another week. He's awake this morning and talking to me for the first time since he came down 3.5 weeks ago. But I would estimate his stay so far has cost $1.5 million. Fortunately, we're in a country where we can do that. But the gear is expensive. A defibrillator is $80,000, a pacemaker is $20,000. The technology is fabulous, but fabulously expensive.
And does that come through funding, or does that come through the government? How does that?
It comes through the government. It's a real eye-opener when someone comes from another country for care and you end up knowing how much it is because they have to pay for it. I had someone from Ghana come last year who needed a bypass operation, a defibrillator, and about a 2-week hospital stay, $220,000.
Thank you.
Thanks, Clarissa. I enjoyed your journey, and you were really nervous before, and you've got nothing to be nervous about. But my question is to David. What is known? Are there any sex differences? What is known? What's not known? Is it equal distribution?
So, yes, there are, and I'll tell you a fun one, and if you can work out the answer, you get a big prize. If you're a person in the community, your chance of having a baby with congenital heart disease is about 1%. If you're a dad with congenital heart disease, your chance of having a baby with the same thing is about 2%. If you're a mum, the chance is about 4%. Go figure, what are the genetics there? Mitochondrial DNA. There are slightly more men with some of the serious kinds of congenital heart disease than women, but the outstanding gender difference seems to be the risk of inheritance.
I have a much lighter-hearted sort of question, trying to be on theme, yeah. So, Clarissa, at the end of the day, from our point of view, that we're all here for you and for people like you moving forward. And you know, we're in the country where with the best healthcare that's enabled you to help you. But I think from my point of view is as an ordinary citizen, I wanted to know what we can do if we identify or if we know there's a family member who are diagnosed with ACHD, or we've got friends, you know, got family that they actually have those patients. How do we prepare ourselves mentally? Not so much about physically, because that's a lot of care happening there. What can we do to contribute and to help families, you know, with patients like Clarissa, and how we can really contribute? Any tips we can take away with today, and that will be much appreciated, Professor David the Goat.
Look, I mean, for me, it's always been hard. I'm one of 4. I'm also a twin who is in the audience tonight. Look, I think for me, it's all I've ever known, but I think the fact that all my friends have grown up with me, some since I was from the age of 3. So the support they've given me throughout my entire life has been second to none. They're like family. They have come on that journey with me. I think just being there, I do have my days where I'm literally in tears, and my sister and my friends have all seen that. There's times when I get really down because I don't have a partner, or I can't have children. It's a number of things. I think them understanding where I'm coming from and putting themselves in my shoes and just understanding how I would feel. Yeah, it's really hard. It's a hard question. But yeah, I think for me, I've grown up with it from day dot, and my support has been fantastic. What I'd need is just kind, understanding friends, which I have, and I've got a great, work colleagues that have been there from, some of them from when I first started, and they've all been very supportive of me coming and going, doing all my tests and unplanned hospital admissions, and me calling David going, I don't feel so great. But yeah, look, I think just the support and being in my shoes and understanding where I'm coming from on the days that I am down.
Thank you very much. Sorry, if you don't mind me putting the mum on the spot, or if there's anything the family could share. Yeah, just share a little bit insight,
Look, Clarissa went into heart failure when she was.
Thank you so much.
When she was 6 days old. She was born at 32 weeks. Well, she was born at 38 weeks, but she was only 32 weeks developed. So when she went into heart failure, and they took her away to Prince Henry Hospital at the time to have some tests. I was in Paddington Women's Hospital, and they said, oh no, it's okay. And they brought her back and they said, no, she's fine. It's just feeding problems. And that took a lot, even to find out that she was going to another hospital for tests because they thought she'd gone into heart failure. Well, she had, but I don't know why they didn't work out what was wrong then. But it was Dr. Celemajer Senior at 6 months old, because we did see another cardiologist at the time, because at 3 months Clarissa stopped feeding and I had to feed her with an eyedropper. So it's been hard right from the very beginning. And you just have to be there. You have to be there for them, and you have to be prepared yourself. When she was a baby, we'd go into the hospital and you'd make friends with all the other parents that were there with their babies. And you'd go in one morning and that baby wasn't there anymore. So you have to be there and expect the unexpected, and it's horrible. And when this started a few years ago with Clarissa and the racing heart, we thought, oh, okay, here we go again. Because we knew it was never over. We had never told Clarissa that it wasn't over. We just couldn't tell her.
I am expecting at some stage David will say it's time for another surgery.
Yeah. So, yeah, but it's not just heart issues with Clarissa.
I have so many other
It's
issues.
other things as well. So,
the list is endless.
Yeah.
You never give up.
No, you can't give up. You have to be there, and you're in the best of hands. And we are lucky we live where we do live.
I'd like to give you
I wonder if I could pick up on something that both Clarissa and your mother said, and something that David said earlier. for the reason why Australia is in the position of being where it is. And it's because of two of the people in this city who are the pioneers. I learned at the feet of two goats, John Celemajer, the father, who would be incredibly proud if he was here to see the results of his labour, and the team that you've built up to actually do something with the results of what he's done. So I just wanted to pay tribute to both him and Tim Cartnell, who set the scene for teaching a lot of people like me about congenital heart disease and inspiring you to do the things you've done and build up a team who will make a big difference in this country and internationally. Thank you.
Thank you so much, Ben. And I think that's a really nice way to end this evening. I'm mindful of everyone's time, so yeah, I would like to thank you, Ben, for paying tribute to Professor Celermajer Senior. And David, I think you've stepped into obviously very big shoes, and you've done that remarkably well. So what a talented family. I'd like to thank everybody for joining us tonight. I really do hope that you have found the conversation insightful. I'm sure that you have. So David, thank you for giving us your time this evening. Calum, thank you to you as well. And Clarissa and family, thank you to you as well for bravely sharing your story and talking about some things that I'm sure have been very painful through the course of the years. So we truly appreciate it. If you would like to share some of what you've heard tonight, please do so. We'd love for you to share any learnings that you've had on social media, anything that you can do to help us spread the word about the important work that's being done here at HRI would be much appreciated. And of course, please connect with any of our team if you would like to get involved in providing philanthropic support that fuels the research that's delivered here at HRI. So we are going to close out now. Please keep an eye out for our next upcoming seminar. It will be held to profile the work of Dr. Chris Stanley and team. So we'll share more news with you on that in the coming weeks. But for tonight, I'd like to say thank you again to our terrific speakers, and thank you to everyone here tonight and online, including of course Elle. Thank you for sharing the night with us. David's waving good night there. Yeah, thank you for sharing your evening with us, and thank you enormously to the wonderful goat. Enjoy the rest of the night.